As surgeons, all of us have faced this, and we will continue to face this, and we don't know which patients will have this problem. So the predictors are really tough to analyze. But then whatever evidence I have got up to the latest evidence, I try to put it here and give it to you. So most patients, especially with distal radius for us in upper limbs, would come with this kind of a picture where this hand is swollen and the patient comes with a lot of pain. And if you carefully look, I always ask my PGs to document this in terms of, color changes and the loss of sweating and hair, because we are also looking at the sympathetic and parasympathetic system involvement. Classically, undergraduates are taught that there will be patchy osteoporosis in CRPS, but a lot of times you might not find that unless it's a late case. So most of these patients come with pain and limitation of movements. Now, a lot of patients with distal radius fractures who have just come out of the plaster may also come with this, and there'll be always this dilemma between a stiffness because of the plaster, or is it patient has developed CRPS. So you need to be very careful when you evaluate these patients in terms of their movements, in terms of their pain, in terms of other symptoms which are very specific to CRPS. So before we brand the patient to CRPS, you need to be looking at, is it because of immobilization stiffness, or is it because of CRPS itself. At the end of the day, it is a very debilitating, painful condition. There is sensory, motor, autonomic, skin and bone abnormalities. Most of us end up treating the other part. We all dump them with antidepressants and all those things, but we are not treating with why that limb went for dysfunction. So the very specific criteria are there. One of the commonly followed criteria would be the Budapest Criteria, where there is a presence of continuing pain which is like disproportionate to an inciting event. For me, it's like almost similar to compartment syndrome sometimes. So that disproportionate kind of pain with your usual analgesics and NSAIDs, and must report at least one symptom in 3 or more of the following 4 categories. The first category, and also at least one sign in 2 or more of these 4 categories. The first category is the sensory system. There will be hyperalgesia or allodynia in these patients. The next category is the vasomotor. There will be temperature asymmetry or skin color changes or skin color asymmetry. The third is the pseudomotor or the edema, which means sweating changes or sweating asymmetry. And the fourth is the motor or the trophic changes. There could be decreased range of motion, motor dysfunction in terms of weakness or tremor, and trophic changes where you see the skin, dry skin, the nail changes, and also the hair growth which is lost. And at the end of the day, when you want to brand a patient with CRPS, there should be no other diagnosis that better explains the symptoms and signs. Is it because of plaster? Is it because of the fracture? Is it because of patient is completely quite not mobilized? You rule out all those things, and then you come to this diagnosis of a CRPS patient. As I said, for me, it's almost like compartment syndrome. So I have put my management of 4 Ps here. We all know about 6 Ps and 7 Ps. You need to prevent it as much as possible. Physical and occupational therapy plays a huge role. Pharmacological agents and procedures sometimes, and of course patient counseling and psychological intervention. So these are the components of a CRPS. Now how many of you use these drugs? NSAIDs? Any show of hands? Muscle relaxants? Antidepressants? A lot of them. Anticonvulsants? Steroids? Lot of them again. Okay. So these are the ones which commonly are used. Yesterday also when we were judging the poster, I think somebody said I put her on tryptamine and she was fine. But then that's not the case always. So what does evidence says? There's absolutely no major evidence for paracetamol for the degree of pain control, and there'll be some amount of evidence for NSAIDs in CRPS1. Absolutely no evidence for anticonvulsants like carbamazepine, phenytoin, and antidepressants. And there's absolutely no evidence for muscle relaxants. We are unnecessarily giving all these medications for our patients, especially muscle relaxants. So there is no evidence. If you search through the evidence, you hardly would get anything for these kind of things. Corticosteroids may have a positive effect on CRPS1, but we don't know what is the duration and dosage. People have tried from 30 to 100 mg, from 2 weeks to 3 months, but there is no huge evidence for that. So this particular 2022 systematic review shows that prednisolone may be effective in alleviating the CRPS symptoms but of course not much evidence there. So steroids might play a role, but not absolutely no evidence. So I would give you at least 3 or 4 major evidences. One of the major evidence, level 1 evidence, is vitamin C. And vitamin C will save you from a lot of these patients coming back to you again and again. So please, look at the evidence and use vitamin C. Daily supplementation of 500 mg of vitamin C up to about 50 days decrease the 1-year risk of CRPS after wrist fracture. So this has one of the highest evidences if you look at all the systematic reviews here. And it could also prevent CRPS also. If you have a patient you know is a type A kind of personality, or somebody who would not mobilize their hand and wrist and elbow and might be developing CRPS, start them on vitamin C. So there is a very good evidence of vitamin C. Most of this is again 2021 systematic review. The second evidence, bisphosphonates. Bisphosphonates have almost changed the way we have been treating CRPS. Again, level 1 evidence, RCT, systematic analysis of RCTs only this particular studies, and show that the CRPS1, they have a huge role with bisphosphonates. Okay, and again, even parental bisphosphonates are first line of agent. We don't use it in our routine practice, but first line of agent is recommended for bisphosphonates. So the bone mineralization, demineralization often accompanies CRPS, and the bisphosphonates basically inhibit bone resorption, improves pain and edema, and that is how they act in this. The third evidence is ketamine. So you're going slightly towards the invasive procedures now. Ketamine infusion has got a very good role, and so if you have a good anesthetist with you, if you have a good department backup, we work with palliative medicine in our institution, and they give these ketamine infusions, short ketamine infusions for this patient. It works wonders for some of the categories of patients. The fourth evidence is, of course, physiotherapy with in management along with the pharmacological agents, and again a very strong evidence of this graded motor imaging should be there. I'll come to that. What is it? So this is one of the major things which we have been using in our CRPS patients, which is called as a mirror therapy. I'll show you how to do it, and I think all of you should have that in your armamentarium if you're dealing with upper limb fractures. It's basically to create an illusion of normality in the affected limb, and involves concealing the affected limb behind the mirror. I'll show you how we do it. And the non-affected limb is positioned so that reflection is superimposed on that mirror to where the affected limb should be. So the brain is tricked in such a way that what the patient is seeing is the normal limb. Okay? And the brain has been shown to prioritize visual input over proprioceptive input. That is and it's an Indian who described this, who has come out with this studies, and it's a beautiful way of dealing with these patients. And then there is the next step is what is called as graded motor imaging, where participants see a lot of photographic flashcards, because what happens is the patient dissociates their limb completely away from the body part. So that is a problem with CRPS. They don't want to recognize that it is their limb at all. And participants imagine moving the affected limb into the position demonstrated on the photograph, and then the mirror therapy comes. The other last evidence, probably not very strong, is gabapentin. Gabapentin works basically, especially with neuropathic kind of etiology. And if you look at the dose, it's quite high, and generally it's less than about 50% of the patients. So, but then it has positive impacts on depression or exhaustion or sleep disturbances. These are only the end result of CRPS. We are not treating CRPS here. That's why I put this evidence last. And more than half of the patients taking gabapentin will not get meaningful pain alleviation, but may experience negative side effects. As I said, prevention is always better. Regional anesthetic techniques like brachial plexus blockade and then stellate blocks. But stellate blocks, if you put the first stellate block, patient responds, then only it works. Otherwise, it will not work. So don't keep on going on giving stellate ganglion blocks. And then also calcitonin spray is also supposed to be preventive. What we follow at Manipal based on all these evidence. Prevention, we start with vitamin C. Sometimes we give regional anesthetic techniques like brachial plexus, or nowadays we have switched over to sometimes ketamine. Edema management, contrast baths, splinting of the deformities, and of course active assisted mobilization of shoulder and hand, and then the mirror therapy. This is how the mirror therapy works. This is the box you create, and one side it has the mirror like this. Okay, so the patient places the injured or the CRPS limb inside this box here. Okay, and they sit opposite. Therapist and the patient sits opposite here, and on one side is this mirror here, and this is what happens. Okay, this is the injured limb now, and patient has a less grip. There is a lot of pain. There is a lot of swelling. Okay, but then when the patient keeps the same limb inside now, this is the injured limb inside. This is the normal limb here, and he's looking at the mirror, and the brain is tricked that is what is inside the box is the normal limb. And now see the grip, what happens. His grip is really strong. He's assuming this, what he's seeing in the mirror is the normal limb, but actually moving the injured limb inside. Okay? So this is how the mirror therapy happens, which is basically the visual inputs to the brain is much better than the proprioceptive pain, and that's how the mirror therapy works here. We do these stretch board kind of exercises. We also concentrate on the upper limb like this. These are stretch board exercises which can, these pecs are changed, and slowly the range of motion is increased each day so that the amount of flexion increases. So they have a lot of, our occupational therapists have a lot of these gadgets. It's all done there, very cheap. Can be done in your clinic or your nursing homes or hospitals, wherever you want. It doesn't cost much, but they are very, very effective in getting their range of motion. So it's classic shoulder hand syndrome. Shoulder will also be stiff in these patients. So you need to be using all these gadgets here. I said we start on vitamin C for about 12 weeks if the established CRPS is there. Pre-gap 6 weeks if there's a lot of overlay or functional component in these patients. We do give NSAIDs, but then just a short course for about 10 days. And we use this lignocaine and prelocaine cream. Actually, this is by the palliative medicine, so it helps a lot for them in a local control of their pain. And they feel better, so that is used with these. We might add vitamin D or vitamin B12 or calcium in some patients based on the blood levels, nothing else, not routinely otherwise. This is day 1 patient. Hardly any amount of flexion, swollen hand, just barely able to do this. This is how we admit them at least for a week. All these patients, when they come, we insist that they get admitted, and slowly the improvement happens here. This is day 4. By about day 5, they're able to do it, and they're able to have good pain relief. It's not that they get a full fist, but they're able to get good relief of pain, and they start cooperating with you, and that is how it continues at home for them. And by about day 7, you see the edema has disappeared. You can see the veins there, almost able to make a fist like this. So this kind of protocol has been working for us a lot. Bisphosphonates sometimes we use as second line, even though nowadays the evidence is primary kind of first line treatment. And then ketamine infusions we use. All these are invasive procedures. We usually keep them as second line. And local blocks sometimes, and stellate ganglion blocks. So increasing evidence of role of central mediated systems here in the development and maintenance of CRPS. And symptoms are due to changes of cortical processing and neuroinflammatory process. And use these drugs based on the evidence. Please go read about these and know not to use muscle relaxants, anticonvulsants unnecessarily on these patients. And that probably gives a lot of good results. And there's emerging evidence that techniques like mirror therapy, what I showed, is very, very useful.